Hi, my name is Olivia.
My name is Shea.
My name is Adrian.
And I'm Sarah.
And we are investigating the role of Avastin in non-small cell lung cancer. So what is non-small cell lung cancer? Non-small cell lung cancer is a cancer of the lungs. It's a solid tumor that originates from epithelial cells that line the lungs, including the bronchi, bronchioles, and alveoli. Some of the symptoms are a cough that doesn't go away, chest pain, trouble breathing, unexplained weight loss, loss of appetite, wheezing, etc. And there are three main subtypes: adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. So as we learned in class, cancer is often the result of multiple mutations kind of adding up. So I wanted to talk about one mutation in the tumor suppressor gene today. And the tumor suppressor gene I want to talk about is C10ORF97. So it functions by modulating expression of cell cycle regulators such as CDK2, and it essentially causes G1 arrest. The mutation that occurs in this TSG is a single nucleotide polymorphism mutation, also acronymed as SNP216. And this study looked at tissue samples of patients with non-small cell lung cancer and patients with normal lung tissues. And as we can see here, the expression of C10ORF97 is lower in more of the non-small cell lung tissue samples than normal lung tissue samples, which indicates a downregulation of the C10ORF97 in the non-small cell lung cancer samples. However, the reason why the expression of this TSG seems to be lower in patients with the cancer is currently unknown. Now to talk about the hallmarks. One of the key hallmarks of cancer that we know is resisting cell death or apoptosis, and that is something that happens a lot in this cancer. So this study took 12 patients with non-small cell lung cancer, most of them being in stage 1, and 8 controls, and they underwent a lobectomy of tumor tissue, and they measured the gene expressions. So their findings showed that there's a downregulation of apoptosis within the early stages of non-small cell lung cancer, with genes such as CASP10 and CASP8, as we can see with the p-values, they are below 0.05. CASP10 and CASP8 are initiator caspases, and they start apoptotic signaling. However, this was a small study with only 12 participants, so future studies would need to be conducted to confirm these results.
All right, so Avastin is a monoclonal antibody that targets and neutralizes vascular endothelial growth factor, or VEGF, which is a pro-angiogenic factor. This inhibits angiogenesis, or the formation of new blood vessels, which is a hallmark of cancer. All tumors need to attract a new blood supply in order to grow in significant size. As a distress signal from hypoxic cells, VEGF is released from the cancer cells and signaled to the endothelial cells to proliferate and grow new blood vessels. Avastin works by binding to VEGF in order to prevent it from binding to the endothelial cells' VEGF receptor. This limits the blood supply of the tumor, leading to eventual necrosis of the tumor via apoptosis.
How many people are affected by this cancer? So 80 to 85% of lung cancers are non-small cell, while 15 to 20% of lung cancers are small cell.
So how big of a public health problem is this? Well, non-small cell lung cancer accounts for, like Olivia said, between 80 and 85% of all cancer diagnoses. But since around 2006, the incident rates have dropped, and 1% each year in women, and then 2.6% each year in men. The risk of lung cancer is going to increase as you age, as is true with most lung cancers. And in a study of 325,138 patients diagnosed with non-small cell lung cancer, the highest affected population were Black males aged 65 and older. The incidence and mortality rates of non-small cell lung cancer are highest in the developed countries, but this can be due to the fact that it is underdocumented in developing countries. And as you can see from the graph, there is a very low survival rate over the 5 years, depending on what stage you're in. If you were in stage 1, your survival rate can be between 92 and 68%. But if you were in stage 4, your survival rate is between 10 and less than 1%. The risk factors associated with non-small cell lung cancer are smoking, asbestos, ionizing radiation, radon, and air pollution. And as you can see from the top graph, the smoking is very correlated with the incidence of non-small cell lung cancer and lung cancers in general. And then air pollution does not have a strong risk factor association, but it is still considered a risk factor. The main risk factor that everybody sees when we're talking about lung cancer is smoking. So I wanted to look further into how smoking has been affecting lung cancer. So this is a study that was done with 52,264 lung cancer cases in Sweden, and 41,262 of this study were patients with non-small cell lung cancer. And in the included patients, 17,878 were classified as current smokers, 17,966 were classified as former smokers, and 4,624 were classified as never smokers. And as you can see from this graph, there is a very strong correlation between smoking and developing lung cancer. In the proportion of cases, about 10% of all of the cases reported were in those who never smoked, whereas between 40 and 50% were those who smoked. So then we wanted to talk about how, now that we know that smoking is associated, how has it been affecting it now that we know that this is a risk factor? And the answer is not much. As you can see from these graphs, the year of diagnosis and the number of cases, it's still going up, even though we know that smoking is associated. So it seems like even though we know this, it's not the only way to prevent lung cancer, and it doesn't even seem to be a good prevention. We have all these, lung cancer legislations, non-smoking bans, non-smoking ads, and as we can see, there is relatively no effect on the proportion of cases.
All right, so now looking at the efficacy of Avastin, I looked at a study that says Avastin in combination with carboplatin, which is a DNA damage-inducing chemotherapy, and paclitaxel, which is a microtubule stabilizing chemotherapy, is a first-line therapy for advanced non-small cell lung cancer. This study compared the effectiveness of paclitaxel and carboplatin labeled PC to paclitaxel, carboplatin, and bevacizumab, also known as Avastin, labeled as BPC. Looking at the overall survival, the median's overall survival was 2 months more in the group with Avastin. As you can see, the BPC group had a median survival of 12.3 months compared to 10.3 months for the PC group. This overall survival can also be viewed as percentages, with the Avastin group showing slightly more survival at both 1 year and 2 years compared to just the PC group. Looking at the progression-free survival rates, the group with Avastin also showed about 2 more months of progressive-free survival compared to no Avastin. The BPC group had a median progression-free survival of 6.2 months, while the PC group had a median progression-free survival of 4.5 months. While the efficacy of Avastin in combination with paclitaxel and carboplatin proved to be better than without Avastin, it is important to take into consideration the side effect profile. The BPC group with Avastin showed significantly more serious side effects than without Avastin. I have highlighted the instances where the group with Avastin had significantly more serious side effects, and as you can see, all of the side effects except for anemia were much more likely when treated with Avastin. More importantly, if we look at the causes of death, the group with Avastin had 14 deaths from toxic side effects, while the group without Avastin only had 2 deaths. This makes you 7 times more likely to die from treatment with Avastin than without. Finally, looking at the cost-benefit analysis, the price for treatment with just carboplatin and paclitaxel labeled as CP is less than half the cost of treatment when you include Avastin, also known as bevacizumab, denoted by BCP. If we consider the life years gained and quality adjusted life years, the inclusion of Avastin supposes an increase of 0.04 life years gained and 0.05 quality life years adjusted. These two factors can be accounted for in the ICER, which is well over $400,000 for quality adjusted life years and more than $300,000 for life years gained. In conclusion, the addition of Avastin in treating non-small cell lung cancer may not be worth the price for such little gains.
All right, so as mentioned earlier, there are three subtypes of non-small cell lung cancer. You have squamous cell carcinoma, which accounts for about 25% of all non-small cell lung cancer. You have adenocarcinoma, which accounts for about 40%, and large cell carcinoma, which accounts for about 10%. So starting with squamous cell carcinoma, it's more commonly associated with smoking than the other cancers, though incidence has been in decline recently, and that's most likely due to the decline of smoking culture since the 90s and 2000s. This cancer type does have a high likelihood of metastasis, which makes treatment much more difficult, however. Next, adenocarcinoma is the most common subtype. There are numerous differing subtypes of adenocarcinoma, and they all have in common this exceptional heterogeneity. So there's a lot of diversity between these cancer cells. The differing subtypes of adenocarcinoma, they coexist and make effective treatment very difficult because they're high resistance with this heterogeneity. And these typically form in other areas of the lungs like mucus producing cells. Last, we have large cell carcinoma. These are typically faster growing, though they're a little bit more uncommon. They have a very poor 5-year survival rate. It's about 11% in men and 14% in women. Though this one can often be treated initially with surgery because they're actually physically larger than the other subtypes. If we were to move on to evaluation, prognosis, and treatment. So though progression of the disease is considered slower overall, it is common for non-small cell lung cancer to be diagnosed in the late stage. This later diagnosis can be accounted for due to like the presentation of symptoms. They're usually overlooked. So symptoms can include frequent cough, chest pain, hoarseness, unexplained weight loss, fatigue, difficulty breathing. They're often overlooked because they can be associated with other more mild ailments. If cancer is suspected, however, a patient will undergo imaging and biopsy of tissue and questioned to confirm. If it's confirmed, the patient's tissue can be tested to determine the subtype and direct better treatment. A patient's cancer stage is determined through evaluation of the patient, gathering of patient's history, lab results of biopsy, imaging like a CT scan with contrast, and also determining how involved the lymphatic system is. So if it's an earlier stage cancer, this could be surgically resectable. These typically have the best prognosis because you can physically reduce the cell load of the tumor in the patient's body. So the tumor is still isolated, considered easier to remove. Though not all patients are really good candidates for surgery. You could have an older patient, you could have a patient with more comorbidities, and these patients may instead undergo some sort of radiation therapy to reduce that cell load in the cancer. After surgically resectable, you would have locally or regionally advanced tumors. And these typically are treated with combination therapy of radiation and chemotherapy. Some of these candidates may be candidates for surgery depending on the tumor's involvement in the tissue. The last, certainly not least, would be distant metastatic tumors. These typically have a very poor prognosis. Systemic therapy would be required, like chemotherapy, and radiation is unlikely to help the prognosis because the cancer is already spread out of the initial site. And if we're to move on to patient experience, as lung cancer is the leading cause of cancer-related deaths in the US specifically, and non-small cell lung cancer is the most common lung cancer, it's likely that the patient will be in a detrimental headspace upon diagnosis. I know I would be. Treatment plans result in symptom burden, which refers to an increase in negative subjective experiences resulting directly from the aggressive treatment that may be necessary to treat these cancers. A 2020 study showed that greater than 20% of patients suffered from all the MD-ASI symptoms. That stands for the MD Anderson Symptom Inventory. These symptoms include things like fatigue, pain, lack of appetite, distress, nausea, more sort of all the things that can be associated with a cancer patient or cancer treatment. So over 20% of these patients associated with all of those symptoms, except for dry mouth, was the only one that was excluded. And then speaking more to Avastin, as Sarah had covered earlier, since it functions to inhibit VEGF, it reduces the efficiency of endothelial cell regeneration. And this reduced efficiency leads to blood vessels that are much more prone to bleeding. So you can have bleeding gums, bloody nose, anything up to and including, terrible life-threatening hemorrhage.
All right, so just as Adrian had mentioned, there are some specific side effects associated with Avastin, and that is because Avastin binds to serum VEGF, that is mainly produced by platelets. This inhibition of platelet VEGF impairs normal blood vessel function, which is why it impairs bleeding, impaired wound healing. And while this is a targeted therapy that preferentially targets cancerous cells, the off-target effects would narrow the therapeutic index slightly.
So, in conclusion, non-small cell lung cancer is a solid tumor of the lungs, making up 81% of lung cancer diagnoses. Non-small cell lung cancer often has a late diagnosis, which leads to a poor prognosis. Avastin is a VEGF inhibitor, but the cost-benefit analysis shows the medication is more expensive for less benefit and therefore may not be accessible to some patients. Thank you for your time. Yay.